Good morning. Thank you all for making yesterday a wonderful opening day to this year's conference. I want to make a few announcements before we begin. First of all, somebody in the back section of that room, we think, had their Academy pin fall off. And if it's your pin, I will have it. Come see me. Second, many of you have asked, so I was so inspired last night by those living legends. Yes. And many of you have asked, do you videotape that? And I said, I don't know, but we do. We videotape all of this, and if you give us 2 or 3 weeks, it will all be up on the website and downloadable, including the sessions here. So you can use those, when the living legends speak and tell their stories, you can share those with students, with other nurses. I am totally inspired by their stories, and I encourage you to use them to inspire others. I also want to tell those of you who do social media and who tweet that we have a social media help desk. So if you don't and you'd like to, they will help you. It's in the Constitution foyer where you can get help with how to tweet out from this meeting. The hashtag that we're using for the meeting is AAN 15. AAN 15, so tweet away. This morning's New Fellow breakfast was fabulous, and when you see a new fellow and they have the gray New Fellow badge on the bottom of their badge, the tag on the bottom of their badge, please welcome them into the Academy. Many of you have already done that, and they're feeling very much at home and welcome, so thank you, and we're eager to induct them tomorrow night. We also had an Edge Runner breakfast, the e-poster presentation, so those have jump-started a day of substance that will conclude with an evening of camaraderie and appreciation. Please be sure to attend this afternoon's panel policy dialogues, expert panel policy dialogues. And remember, it's your input into those discussions that will help to drive the Academy's policy initiatives. So be engaged, speak up, and help us to figure out the directions we want to go on these topics. We have a great group of speakers and can expect the engaging dialogue will follow. We've scheduled 2 interactive panels for today. The first one focuses on 3 high-profile issues whose short and long-term impact on healthcare is only starting to be understood. The issues are big data, precision medicine, and bioethics. Now, don't forget, you can submit questions at any time during this panel. We'll have Jonas Fellows around who will take your questions, just sort of hold up your card, and they'll take them to Ramon, and he will go through them and bring them to the moderator. We won't necessarily get to all of them, but we'll try. But at the end of the session, there will also be some open mic time. It's now my pleasure to introduce Bernice Coleman, Planning Committee Co-Chair, who will introduce the members of the plenary panel. Bernice?
Good morning, colleagues. I'm going to just briefly introduce our panel, but I'm going to also suggest to you that the full detail of all the panel participants today can be found on page 17 and 18 in your booklet. So today we're very excited to have a distinguished panel. First, let me introduce Dr. Suzanne Bakken, and she is an alumni professor of nursing and a professor of biomedical informatics at Columbia University. She is currently the AAN, ANA, ANF Distinguished Nurse Scholar in Residence at the IOM, where she focuses on big data, the intersect between big data and health equity. We also have Dr. Kathleen Calzone, and she is a senior nurse scientist in research in genetics in the Cancer Institute. Dr. Connie Ulrich is an associate professor of bioethics and nursing at the University of Penn, and she holds a secondary appointment in the Department of Medicine in Ethics and Health Policy in the School of Medicine. Lastly, our distinguished moderator is Mr. Levey, and he is an award-winning national health care reporter for the Los Angeles Times, and Noam. You know I got the other one mixed up. He's also published in both the Journal of Health Affairs and the American Medical Journal. So without further ado, would you help me welcome our distinguished panel?
Well, thank you very much, and welcome everybody. I think we have a very interesting and exciting group of speakers this morning who, as mentioned, will discuss some of the big issues confronting healthcare. Obviously, we don't need to tell you that there are a lot of changes happening in healthcare right now, many of them frightening and inexplicable. And I think our three speakers will potentially scare the bejesus out of you. I think the idea is that each one of them will give a short presentation to talk a little bit about what some of these big forces are that are shaping healthcare right now. And then we'll have a brief discussion up here. I'll ask some questions to get the conversation started, and then we'll take some questions from all of you. So I'm sure we'll have a very spirited discussion. So first, I guess Dr. Bakken, you're first. And do you need I think it's up here, excuse me.
Thanks. It's my great pleasure to be with you here today to share some of my thoughts on big data. And we already know that we're going to have some great discussion among the panelists. So my clicking is not bringing up my slides. So anyway, but I'm going to. Oh, they are. Okay. We don't see them.
There you go.
Okay, thanks. So I was seeing another slide.
Small
So
data.
what I'd like to do is very briefly just talk about three myths related to big data. And so in terms of thinking about big data, one of the myths that's out there is that big data is just about volume, and that's not true. Volume can be important, but it also has to do with the complexity of the data, the extent to which the data is rapidly changing. So when we think about it from the perspective of nursing science and think about a topic that's very prominent in our literature, something like symptom science, and this is the UCSF symptom management model, we can think about what's in blue, which tend to be the type of traditional data sources that people have thought about in symptom science in the past. But when we think about it these days, we think about the complexity of data, and certainly taking into account what is in the pink, which ends up being quantified self-data, which people are collecting on themselves, but also what's in the green, which is much more thinking about omics. And as you all know, many omics are increasingly available. So for many questions that we would want to address from the nursing perspective, we would want that variety of data. A second myth, and this comes up in study sections at times, is that big data is a fishing expedition, and true scientists wouldn't consider doing big data and data science. And so I want to talk a bit about this, and when I think about this from the perspective of science, and people would say, oh, we need to add a big data course to our curriculum. we really need to think about it much more fundamentally from the perspective of philosophy of science and where does big data and data science fit. And so one of the things we need to think about is what are the different techniques we need when we're not talking about sample, when we can access the full population of data. And we have to think about where is the role of these particular methods in our science and as we prepare nurse scientists. And thinking about the role of methods which much more focus on understanding the relationship rather than hypothesis testing. So it's not the be-all to end-all. It has its place in the production of nursing knowledge. And I just give an example. I'm from Columbia University. This is an article produced by two of our junior faculty, which talked about how by doing data science analytic methods, they could demonstrate that actually Twitter showed up earlier in being able to describe the Ebola epidemic in Africa. And then the third myth I want to talk about is that big data is not for nursing. The last time I was on this stage, I think it was this stage, or it was this meeting, talking about big data. So the faint diagram that you can see is Florence Nightingale's Rose diagram, where she was bringing together multiple data sources with the technology that was available to her at that point in time. The last time I spoke about this to this group, Susan Gennaro ended up asking Patty Brennan and I to write a topic. So this is out in the Journal of Nursing Scholarship. So indeed, we're arguing that big data and data science methods are very relevant to nursing, and that indeed that we have much to offer the broader field of data science. And so I just wanted to show you one more slide in the theme of, yes, data science is for nursing. And this is from some work that was recently funded by NIH and INR as part of their self-management portfolio. And we're studying dementia caregiving, and we're wanting to understand what are the network structures of the people who tweet about dementia. And so this is a macro level structure, and then we can go deeper into that structure and get a sense of more what we would call the meso network. And then we go into looking at a smaller network. So this is really looking at who's talking to who, which requires a particular set of algorithms and analytic methods. But we're also interested in what are they talking about, who's tweeting and retweeting. And so this requires another type of analysis which takes into account looking at the linguistics, what's frequently talked about, doing topic modeling, and then also trying to assess the sentiments. So we think these methods that big data and data science is relevant to advancing nursing knowledge and the type of research that we do. And I'll leave it at that and turn it over to precision medicine.
Dr. Calzone?
Thank you very much. I'm going to start with a discussion about precision medicine, and hopefully you'll be able to see my slides, which I can't see. I have a mutation in my technology gene, so. Okay, so I want to spend a couple minutes sort of introducing this concept of precision medicine and distinguish that between Precision Medicine Initiative, which was launched and announced at President Obama's State of the Union address this past January. So precision medicine is essentially a mechanism for the use of genetic and genomic information and individual variability in informing therapeutics. And so it is sort of crossing not just the medicine continuum, but therapeutics as a whole. The Precision Medicine Initiative is intended to be a mechanism by which to accelerate evidence generation to be able to translate these discoveries into healthcare. And there are two components to this initiative. The first one has to do with further work in cancer, which is sort of the poster child for where we begin to see the outcomes associated with precision medicine, and with an emphasis on items such as looking at drug resistance and those kinds of challenges that we have. But the second piece has to do with being able to engage some of the large existing research cohorts that we already have, such as the Nurses' Health Study and the Women's Health Initiative, and expand that and build upon that with citizens across the United States to have a cohort of individuals who would be willing to participate in a research effort to inform precision medicine. This will be more than 1 million Americans, and this is something where the platform proposal for how this would be done has already been established and was announced back in September. And I'd encourage you all to look at it. It is a missed opportunity for nursing because we were not able to be as engaged in that process, but it's never too late to have input into how this actually functions. The next piece is sort of thinking about what does precision medicine have to do with nursing and where this is going. And the very first thing that I think is essential to understanding this is to recognize that we have a massive translational capacity problem. And this is not about, nursing, educating nursing. This is an interprofessional issue, and it's one in which nursing is uniquely positioned to be able to take a leadership role. We have vast examples of things that have been very successful, such as quality initiatives, the geriatric initiative, end of life. We can engage the interprofessional healthcare community. We have infrastructures that have been very helpful in sort of setting frameworks for what kinds of education for preparing their future nursing workforce. And those are models that can be useful in thinking about how to roll this out for an entire workforce that has a limited capacity to utilize this information. And recognize that the more data that we generate, the less capacity we still have because we don't have people who understand how to really use this. And translation has to be realistic. I think nursing is uniquely positioned to understand what really can be done in the bedside and in the delivery of healthcare. And I'm going to use family history as an example of that because family history provides us with an example of the traditional genetic perspective of the 3-generation pedigree, and is that really feasible in the general healthcare environment? And we've had 20 years of experience to see that the adoption and the infrastructure to support that has been limited. And yet in the genetic specialty arena, yes, absolutely, and I fully endorse that kind of family history. And I endorse having healthcare providers understand the basic tenets from a competency perspective, but what kinds of things are really feasible in practice may be more targeted based on the environment in which someone practices. From a perspective of research and nursing science, we have to appreciate that pathways forward into precision medicine have to be evidence-based. And this is an effort that's been one that has been pursued collaboratively between the Cancer Institute, the Genome Institute, and the National Institute of Nursing Research to establish the genomic nursing science blueprint and take that to the next step of beginning to develop infrastructure that could support the generation of evidence that could really further accelerate this, such as instead of independent scientists doing their own research, is establishing research consortiums, looking at areas where we have gaps in common data elements and beginning to build those infrastructures so that we can generate evidence that is quicker and faster to answer these important questions. And precision medicine provides us with a challenge of recognizing that we could be identifying therapeutic gaps for common healthcare conditions. Our infrastructure in the US is one size fits all. That is the nature of drug discovery and therapeutic decision making. And yet the more precise we get, the more we will begin to identify people for which therapeutic options may be far more limited than would be traditionally expected for common health conditions. I think that nursing as a whole has a unique opportunity for translation, and I'll highlight an example from NINR of sort of looking at the Precision Medicine Initiative and then NINR's adoption of that in terms of nursing science through their website. And in addition to that, I think that nursing is poised to be able to provide guidance for solutions. And solutions can be looking at existing models, like the model from the Human Genome Project with the ethical, legal, and social implications, where portions of budgets were allocated to deal with these issues. And there could be interprofessional incentives in which to inform that. The Academy in particular has opportunities to be able to do horizon scanning, capitalizing on the work of the expert panels, and recognize that we have one that's massive, that's on our forefront right now, which is the advance notice of proposed rulemaking associated with the Common Rule. And if you look at that document, and we have opportunities to have comments through December, this is something where the use of biospecimens and consent are vastly different than things we've expected. And so being able to respond to those queries and to provide input and to participate in stakeholder engagement is very important. Looking and participating in strategic planning and other kinds of advisory councils and being aware of those things provides us with an opportunity to recognize what's coming ahead and be at the table instead of responding at the back end once a report has already been generated. And being consistent with our messaging, which I think is always important. In precision medicine, this cannot be something about nursing asking for more money, but trying to create solutions and being articulate about what role nursing plays and where nursing contributions can be important. So I'm going to end here and just make sure that you recognize that nursing has a role in precision medicine, and precision medicine impacts the entire healthcare continuum. This is not about single gene disorders. This is the application of genomics across the healthcare continuum, and nursing is uniquely positioned to inform in the science and the discovery, to be able to think about how we're going to be able to utilize this and practice efficaciously, and the end goal is to improve health outcomes.
Thank you. Dr. Ulrich?
Thank you. Thank you so much. It's terrific to be here with my colleagues, and especially to see Kathy again, who I've known from the National Institutes of Health, so it's terrific. Hopefully I won't frighten you with the bioethical sort of implications, but I would like to have a dialogue about some of these bioethical implications. So I thank you for the opportunity to discuss these two very important emerging areas of scientific inquiry. I think both of these areas have certainly piqued our interest with regards to how we can certainly think about reshaping the conduct of our research, how we practice and care for our patients at the bedside, and also how we teach our students. So it seems like there are a lot of benefits to both of these areas, and one might question, do the benefits really outweigh the risks, and what is an ethicist doing on this panel, so why do we need an ethicist, and what should we be really worried about, right? But I am worried. I do have some concerns. I think with any technology, new and emerging technology, we have to ask ourselves several questions. What is the purpose? Why do we need it? How do we use it? Whom will it benefit? And what are the potential harms? And the harms to patients, to families, to communities, to our society. And so I think these are broad questions for us to really have a significant dialogue about. And I also think because we are here at the Academy and we're thinking about the overall health and well-being of the public, what is the role of nursing? I think, as you said, Kathy, what is the role of nursing in shaping policy and dialogue for the betterment of our patients and their families? So I'd like to share with you this quote. Let me see if I can pull this up. This was a quote that was published in 1950. I don't know if many of you remember Life magazine. It's sort of a general entertainment, I think, a general interest magazine, but I love this quote. It was by Elvin Stakeman, and it reads the following: "Science cannot stop while ethics catches up, and nobody should expect scientists to do all the thinking for the country." I love this for a variety of reasons. One, it is true, you know, ethics is usually catching up. With any new technology, new method, new approach, new scientific endeavor, we're always catching up. And I think that has been true throughout our history. We only have to look to research ethics to understand that. We can look at, for example, the Tuskegee syphilis public health study that continued for 40 years, from 1932 to 1972. And it made us really question the ethical conduct of research and how do we protect human participants, particularly those that are the most vulnerable within our society. And secondly, I think this is right. Scientists should not do all the thinking for the country. We are scientists here, yes, but I do believe that nurses, in particular at all levels, have a role to play to help us think about what are these harms and what are these benefits for our patients, especially when we're thinking about how do we translate that information from the bench to the bedside. And that will be really key for nurses, I think, to have a voice with regards to those particular issues. So you might be wondering, well, what are, you know, sort of these ethical concerns that I am really worried about? And I think there are several, and I have them here. I am worried a bit about this issue of informed consent. What does that really mean? How do we help people become informed, especially related to the issue of privacy in particular, and the benefits and harms associated with that, and also I think with regards to the role of information pertaining to research and the role of information that pertains to clinical care and how we're blending the two, because I think sometimes there is a blurry distinction between those two, and I'm not sure patients always understand that, nor do clinicians or researchers always understand the role of these two aspects. So let me share some concerns with regards to informed consent. I'd like to share a true story, actually, that happened with a colleague of mine and a friend, and she actually gave me informed consent to share this particular issue that happened to her. And it gets to this issue of privacy. What does that really mean? And also the role of informed consent. Can one ever truly be informed and fully consenting, or the lack thereof? So my colleague received an invitational letter to participate in a research study by a principal investigator through her home academic community. And the study was focusing on looking at advancements for uterine cancer, or ways for early diagnosis of uterine cancer for women who were diagnosed with endometrial cancer. And my colleague was recruited for this particular study because she recently had gynecological treatment and care at the hospital within her home academic setting. So to her surprise, she received this recruitment letter, of which her personal health information was identified: her name, her home, her telephone number, and her cancer diagnosis. And as you can imagine, when you're diagnosed with cancer, that is a very sensitive issue, and it's a very private issue. And it's one that my colleague did not share with any of her other colleagues. And you can understand why, by virtue of being within that academic society and working across different disciplines. She just did not want to share that information, and she felt that that information was private. Well, she became very concerned, and also in that recruitment letter, it indicated that the principal investigator had already asked the oncologist who took care of her to provide other private health information via the electronic medical record. And that had already been approved by the Institutional Review Board. So I became involved in helping her think about what are the bioethical issues here related to privacy. And when we're linking data within these learning healthcare systems and massive amounts of data, what does privacy really mean? She didn't recognize or understand that she was actually opting in to research, not opting out. And I think many patients do not understand this distinction. When you're going into a hospital within a learning healthcare system, she was opting in. So therefore, she was being targeted with regards to her diagnosis, or perhaps her disease, or perhaps some other particular issue of concern. She was not opting out. And so I'm not sure that patients really understand that distinction of how their information is going to be used, and how can we ever have complete privacy. I'm not sure that we can. We certainly can develop guidelines and policies and procedures, and nurses certainly need to be in that realm to help us better understand those particular issues. So I am worried in the sense that we're using all of this data, we're collecting data both internally and externally, linking it together, and I do worry that perhaps with big data, for example, even though we might not have de-identified data, will we be creating such a unique data set that we might be able to identify someone readily? And I'll be curious to hear what Susan's thoughts about that particular issue. So I think there are many, many concerns here that we need to think through. The other issue that I'm really worried about is just education, especially with regards to precision medicine. Let's say my colleague now had whole genome sequencing, and that information was now uploaded to the electronic medical record, which it is occurring. And she is participating in this study, but now the researchers have access to that information, which was not part of the original study. So it gets to your point, Susan, with regards to how much data is too much data. We now have access to large volumes of information that might not be readily pertainable to that research question. So is there a fishing expedition that we have to be very careful about here with regards to private information? And then lastly, I think I would say I am worried about the following. That is, we talk about the role of clinicians and informed consent and having those conversations, particularly with precision medicine. I'm a bit worried that patients might be expecting more than we can give. And who should have that conversation? I think we do know with regards to clinicians that they don't necessarily feel comfortable nor confident having discussions related to other areas that we care about, such as end of life or palliative care. So will they really feel comfortable with regards to having discussions surrounding precision medicine within the clinical setting pertaining to the benefits and risks for patients? So I think we have a long way to go. I think nurses certainly will be key. I think we will need to have team science and collaborative science that will bring in researchers, academicians, clinicians, statisticians, and others, and geneticists to help us better understand both of these areas as we go forward and to be thoughtful. And I certainly think nurses will be key in that role. So thank you.
Thank you so much. We have a lot of questions to get to, but before, as I'm sure it's shocking, but before we get there, Dr. Ulrich, you raised a number of points, I think, which it would be interesting to hear, at least briefly, from the two of you about how patients' information can be protected in the course of gathering big data sets and in the course of developing precision data on individual patients. Both of these big data and precision medicine obviously hold great promise, but can each of you talk at least briefly a little bit about some of the issues that Dr. Ulrich raised vis-a-vis privacy?
Yeah, I completely agree with concerns and have some additional concerns. So I think it is vital that we look at informed consent procedures and do kind of layered consent. We've done some work with some of our big data sets with our local Latino community, and we know one of the things that absolutely predicts consent for the different components of precision medicine is, and by that I mean future research contact, data linkage, reuse of data, collection of biospecimen is the biggest predictor of consent across those, and our data is actually health literacy. And so I've actually been very visible at some of the NIH precision medicine stakeholder groups and bringing forth some of those data. One of the data sources that I worry about a lot that's not a clinical data source is many of us use social media, and some of the terms of agreement are like 64 pages. No one uses them. No one actually reads them. So thinking about it from the perspective of when we think about these sites, there's the notion of you're a consumer of the site, but by consuming that site, you produce data. And that can be used by others. And if you know how that data is going to be used and you agree to it, it's fine. But because of the complexity of those consent forms, we end up having instances, particularly of people who might have low levels of health literacy, end up having their data commoditized and sold for purposes that they wouldn't choose to have it used in that way. So I agree that some of the privacy concerns end up being beyond, they end up being related to some of that quantified self data, not just not just the clinical data or the genomic data as well. So it is a broad concern. And I just want to say one thing in Kathy's point is we completely agree on the centrality of nursing for precision medicine. So when Columbia did their response to the minority and health disparities precision medicine, it was led by a nurse. Okay.
Dr. Calzone, do you want to talk a little bit about some of the issues of privacy and safeguarding data?
So in the genomic era, so that's the framework that I'm going to take here, we have to appreciate that genomic data is the ultimate identifier. And so at the end of the day, we have to rethink what we think about as identifiability, right? Because in any kind of data set, the coding of data, the numeric, I put a number on a biospecimen and the genomic data that came out of the sequencer is coded with that number. It's irrelevant because genomic data in and of itself is identifiable. So we need to rethink what we talk about when we think about privacy in the genomic era. That's my first point. My second point has to do with how we actually consent people to participate in this. As Dr. Ulrich mentioned, we need to rethink methodologies. You know, the 30-page consent form like you highlighted is completely inappropriate, but we need to be transparent. We have to be able to explain to people, and the evidence thus far has indicated that as long as you're transparent to people, that people are generally willing to consider participation in these kinds of things. We are needing to have the evidence to inform us about the best methodologies to begin to roll these kinds of things forward and to set up infrastructure such as, you know, in these large data sets that are publicly accessible, such as dbGaP and those kinds of things where, you know, what constitutes controlled access and what will investigators who utilize those kinds of databases actually do with that data? And will they not use it for the purposes of identification? And so I think that there's a lot of work from a policy perspective that still needs to be done, but we have to appreciate where we are, which is the cat is out of the bag and DNA is the ultimate identifier.
Can I say something to Kathy?
Sure.
Because I think she's right. I mean, my worry is when we're uploading whole genome sequencing to electronic medical records, what does that mean? Who has access to that information? A variety of individuals might have access to that information when my colleague, for example, might not want that information to be known. That's private and sensitive types of information that we have to be very careful about who actually has access to that data. So I totally agree with you on that point.
So I don't want to spend the entire panel talking about how frightening and disturbing all of this is, so we should probably try to talk a little bit about some of the promise that big data and precision medicine offer. Both of you talked a little bit about this in your introductory remarks, but I have a question here from the audience that asks a little bit about how precision medicine and big data, I think we can add into this, can inform the national and local work to build healthier communities. Do you want to start?
Yeah. Thank you. I feel like that was a planted question, so I'm delighted to talk about that. And one of the things, and I'm going to tie it back to the notion, to an ethical issue, and the notion of really thinking about benefits and risks. And one of the ways we have tried to tie it back is making sure that we feed the data back to the communities and the community members themselves. So when we've collected a large volume of data on about 6,000 Latinos in our community, we worked with them to figure out how they would like to receive it back, and then have been testing that, and then we have created the infographics tailored to their particular needs to give that data back to the research participants, and also aggregate data to the community-based organizations and to our local health care organization to really say, if we're going to collect this, let's give it back, let's do data-driven community engagement, let's continue to build the fabric of trust in the community. And so how we're thinking about this and working with the genetics experts at Columbia is how do we take those lessons of community engagement, participatory design, expand the type of data that we're reporting, but use some of those same methods, so we really can balance that risk and the risk and benefit, and not have it be about the scientific publication. And we actually gave the data back to them first, just as a measure of what we wanted to do in terms of having that trust relationship.
I think that's terrific strategy, Susan, because I think one of my worries from a bioethical perspective with regards to precision medicine in particular is that will it increase health disparities or will it decrease health disparities? By virtue of not having access, communities not having that access to targeted therapies, therefore they will not be able to have that specific benefit that might benefit them in the future.
Dr. Calzone, is there a role for precision medicine in this effort to make healthier communities as well?
Absolutely. So, the infrastructure that we have now is the evidence says that this works 80% of the time. And being able to be far more specific and precise about who will respond to particular interventions is highly informative in being able to improve the outcomes of people. It's also highly important because some of the things where we have robust evidence that should be and not, it is not as adopted as it should be, but things like pharmacogenomics and simple agents like Plavix and being able to use those kinds of tools to identify who will and won't respond to those agents to reduce readmission, to reduce the potential for a failure from a cardiovascular device, and those kinds of opportunities can both be a substantial cost savings for our healthcare community as a whole, and also can improve the outcomes because you're making choices that are far more informed based on the genomic information than you would have had otherwise.
And does some of that work, both from a genomic perspective and from a data perspective, bear at all on the discussion that we're having about cost effectiveness as well?
Well, I don't want to interrupt. Let me just briefly say something to that, because I think that's an issue of justice and allocation of resources, right? And how we're spending our money with regards to whether or not we should be focused on something else, for example, for prevention. That might be more cost effective than precision medicine.
Right.
Because precision medicine might take a long time before we get to a standard of care. With regards to that. So I think that is a major bioethical concern, and I'm not sure that we have fleshed through that, but it certainly is something that is open for dialogue.
I agree.
No, go ahead.
Okay, I agree about it from thinking about it from a justice perspective as well, and that's why I think it's so vital, given nurses' history of working with underserved populations, having great communication skills, practicing the community, doing research in the community, is we need to make sure that these big data sources have a representative sample, because if individuals aren't in it, you're not be able to design the treatments that are going to be most relevant to them from both from an N of 1 and a population health perspective. And that ends up being not cost effective. So I think it's very important that we really figure out how much work needs to go into that ahead of time, because it is going to be more expensive to build more than 1 million person cohort and truly have it meet the diversity goals. But I feel very optimistic that it will be worth it in the long run. And I was able to do 6 town halls with our local Dominican community, and they were very encouraged by efforts of this and being able to provide specimens that might provide the foundation for some of the diseases that particularly affect them more than others, and being able to have because the most tailored treatment should be the most cost-effective in the long run.
But I think this also gets to another important point, Susan. With regards to big data, with the volumes of data, we certainly will be able to find statistical significance, right, with large volumes of data. But what is the clinical meaningfulness of that information? I think we will have to be very careful about how we interpret that and what that means for the future for population health.
No, I couldn't agree more. And there haven't been, and when you really think about it, there is not yet the tradition of really thinking about what would be the criteria for what would constitute a highly reliable, valid, big data study in terms of what do you need to know about the algorithm?
Yes.
How did it work? What data sources came,
Yes.
et cetera, those kinds of things. So we really need to think about what are the criteria we want for publications about that, because but anyone who does knowledge discovery and big data, there are major points in which there is domain expertise, both at the beginning, in the middle, and at the end with the major data interpretation, because obviously with the volume, the statistical significance ends up being, traditional notions of it are completely irrelevant. So you really want to be looking more at patterns and what they mean, and looking at that from the perspective of what's the knowledge, what's the interpretation.
Yeah, how do you sort of decipher the truth from the noise, with regards to all of that data that you have access to?
Yeah, absolutely.
Yeah, go ahead.
So I want to bring up, related to that, sort of feeding onto that, because both of you are sort of talking about sort of what is practical from a health perspective of the data that's generated, and then the analysis that it takes. If you pay attention to anything that's associated with precision medicine, the goal is the infamous $1,000 genome, which we've actually have the technical capacity to do the $1,000 genome. And in fact, it's the hundreds and hundreds of thousands of dollars to do that analysis. And so there is a big sort of cost implication of trying to roll this out, because this is where the cost is going to be, is doing that kind of analysis and teasing out then what is relevant to healthcare and what is a relative risk of 1.1, and what actually would you do with that information, which is largely nothing, depending on what it's associated with.
I mean, Dr. Calzone, just to build on that a little bit, I mean, there is a concern. If you look at the polls of what public is concerned about, their top two concerns relate to the cost of drugs now, which is amazing because not that many people take very high-cost drugs, but clearly this is something that's weighing on people. Precision medicine, I think from a layperson's perspective at least, might be looked at as, well, that's great, it's very exciting, some way down the road, but is some pharmaceutical company going to charge me $10,000 a pill once they have my specific genetic information? I mean, is that a concern that we need to, how do we deal with
evidence
that?
of that already. So the answer to that is yes, that is a concern. On the other hand, part of precision medicine is being able to make more informed healthcare choices. Is it agent A or agent B, as opposed to the trial and error approach? Is agent A going to result in significant toxicities for a given group of individuals, and could you avoid that instead of waiting for someone to have a rash all over their body that takes them to the emergency department? Are those kinds of things avoidable by the appropriate and informed use of genomic information? And the answer to that is likely yes. And in certain circumstances, we already see how that can inform some of our healthcare decisions now. It is, though, a very difficult balance in the challenge that some of these therapies that are designed specifically targeting genetic defects like in cancer of an individual's tumor can be massively expensive and cost prohibitive. And what you have is an ethical issue of basically a population of people who can't afford the therapy that is proven to work for them.
Well, we have about 10 minutes left, and I want to open it up for questions from the audience. There are two microphones. One is over there, and I think one is over there. If folks have questions and want to go to the mic, we have about 10 minutes left, and take the conversation in any direction you want to go. Anybody? Or I can keep going.
I have a question because I'm from El Paso. We all know Mexican American, they are very poor, so I don't think they can pick agent A or B. Although we have a healthcare reform or Affordable Care Act, it's already past grace period, so everybody's supposed to have insurance, but that is not true. Plus, we have 17 million undocumented Hispanics, so they don't have insurance, as I can see in clinical. So in this case, how can they pick that the treatment precise design for them, because they have no choice? That's my first question. The second question is about the informed consent. Because in my experience in El Paso, we figured out, because their literacy, we need to design the consent form in very easy, like a 3 or 4th grade level. And then reimbursement, cash. Other than cash, it doesn't work because they need money. And if you only collect questionnaire, it's about 25. That's kind of routine price. If you collect specimen, that would be about 50. More than that, it's a coercion. So sometimes when we design the informed consent, we need to tell them, okay, because they don't have insurance, so this study might help you to do something. I know NIH will ask me, say, how do you refer them to a doctor? I can't, because a lot of them are undocumented. I cannot refer them to certain doctor. So I will give them record and have them take to somebody they trust.
Thanks.
So
Those are two great questions. So why don't we start with the second one first? Do you want to talk quickly about that, and then we can get to some of the ethical issues with access?
Yeah. We, in the population that we've worked with in Washington Heights, Inwood, it's predominantly Dominican immigrants, more than 80%. We have dealt with issues of both consenting and compensation for the time. We do provide compensation typically in the way of grocery coupons rather than actual cash. That's what works in our community. We don't check whether or not they're documented at all. And so we know that we have some proportion of undocumented. We're very, very careful about our consent processes in terms of the majority of our data was collected in Spanish. We have our consent administrators and data collectors are from the community, and we collect, the majority of our data is collected in Spanish. So it's not a cheap data collection. And it does take a lot of attention to kind of build that trust and then figure out, of course, you need a safety plan if you detect something in the data, and then figuring out how you would make something that would work. And so I think it's vital, it's so important that we work hard to get the type of patients that you're talking about involved in these initiatives. We just have to realize it's going to cost more because it's going to take more effort, but it's incredibly important. If we're going to reduce health disparities, we got to do it.
Dr. Ulrich, really quickly, do you want to address the issue of access to these choices? Is there, the Affordable Care Act was obviously supposed to expand access to insurance and by extension medical care. Are there additional policy interventions that you think are necessary to give people the ability to make the kind of choices that Dr. Calzone is talking about?
Well, I think that, can I just address the informed consent issue first, because that's, I've done a lot of work with regards to informed consent, and I think that still remains such a significant concern for us, especially with vulnerable populations, and what is it that we really want them to know with regards to participating in the research trial, and how much should we compensate them for participating in the research trial. And I think, compensating research participants actually is a measure of respect for them. But I think the data, we still need more data to better understand how much is too much. I think as the individual commented with regards to coercion or undue inducement for individuals participating in that particular research. So we're still not clear on that particular issue. With regards to access, yes, I think that still will remain a significant policy issue for us that we struggle with and that we will need further dialogue to discuss.
Mm-hmm. Is there a question over on this side?
Yes. My name is Lena Gould. I'm the founder of the Diversity in Nurse Anesthesia Mentorship Program. I'm so glad that you brought up the issue of informed consent, especially with patient population that have English as a second language. And I think especially in the operating rooms across the United States, especially when we're trying to get consent for the operating room procedures, for OB, for C-sections, for cardiac catheterizations, it's very important that we speak to the patients who cannot either speak the language or cannot write the language, that somehow we have that where we can structure it in a way that they have it written and they can fully understand. Yes, we can rely on the language line, but that's fine. But I think we also need to have nurses who are bilingual to make sure that these patients are fully informed.
Yes.
So.
I absolutely agree with your comment. I mean, I think sometimes we treat informed consent just as a one-time endeavor. It really should be a process. And we just need so much more thinking. Much of the research, and my colleague indicated to me that NIH has funded research on informed consent for the past 20 years, which is terrific, and I hope it continues. But much of that research has been on research ethics and informed consent, not so much the ethics in clinical care. And I think we need much more research on informed consent in clinical care, because I think that's completely different. There might be some similarities with regards to informed consent in research, but I think there are also differences and nuances that we're not really clear about.
I would just point out that I can't remember if it was earlier this year, it might have been last autumn, the Institute of Medicine Roundtable on Health Literacy had a workshop that was on informed consent, thinking about it both from the perspective of research and clinical care. And the proceedings of that are available from IOM. So these are critically important points.
I think we have time for one more question, maybe from over here.
Linda Bauman, University of Wisconsin-Madison. My question is about big data, and it requires a different approach to research and asking different kinds of questions. So how do you learn to ask the right question that addresses big data?
Yeah, I'm thinking a lot about this because I'm speaking at the AACN conference in January, and there's going to be something in the doctoral pre-conference, and then Patty Brennan and Bonnie Westra and I are all speaking in the main conference as well. So more to come. How I think about this is data science isn't a separate methods course. You start in your theoretical and conceptual foundations thinking back to philosophy of science. What is science? What does it mean? That it goes through the various courses. It goes through methods. It has to be threaded. It has to be threaded through a design course, a quantitative methods course, but it also needs to be threaded through an ethics course. So there's not a simple answer, and it shouldn't. It needs to be, because it is a different way of approaching a research question, and so we need to think. If we don't do those early parts on thinking about it from a philosophy of science perspective and from a theoretical and conceptual foundation of nursing perspective, people are not going to be asking questions that are appropriate to the method. So like anything else, it needs to match up.
I absolutely agree with you, Susan. I think we forget about the ethics of research design, you know, and the questions that we want to ask and the assumptions associated with the data and the biases associated with the data. So we need to be much more proactive and thinking about that as well. So.
Well, thank you all. Oh, we got one more. I'm sorry, we have time for one more question, don't we? I guess back over here.
Ann Turner Henson, University of Alabama at Birmingham. I want to speak to the Million Americans study. There was a study several years ago called the National Children's Study that was going to look at children across the lifespan. I'd like for the panel to speak to the defunding of that and how they see this new study meeting the needs of understanding disease across the lifespan, when many adult diseases we know begin in childhood. Thank you.
Who wants to take that?
Well, I'll start. Yeah, so, you know, there's no question that we have a funding challenge. We continue to have funding challenges. And so the degree to which this, will be funded with the current infrastructure is still something that remains to be seen. I think that it is the first foray into how to begin to do this, and I agree wholeheartedly that many of these kinds of health conditions can be informed by engaging pediatric subjects and following people across the lifespan. And in fact, you know, right from infancy or the beginning of life throughout a lifespan. But it is very challenging from the perspective of consent.
Yes.
And from the perspective of sustained funding to continue to provide the infrastructure necessary to be able to enroll and collect data from a cohort of that magnitude over what essentially is a lifespan. And so I think that there's still a lot of work to be considered in thinking about rolling this out.
Study, the defunding of the National Children's Study is not going to be answered in the Million Americans study. And I think that that's something that the Academy needs to really consider, because if we think about, and actually the National Children's Study started pre-conception. So we're missing an opportunity to really understand about the disease process and how genomics, environment, and lifestyle interact.
Yes.
I would just mention that in all the RFPs that I've read and in the process of applying for, everything says you must take a life course. You must take a life course perspective, and that's not the. And we hope that it's not token. And I had the opportunity to hear the interim NCI director speak before the Senate Appropriations Committee last week, and he made it very clear. He highlighted some of the stuff at NCI that's going to be very focused on children rather than adults. That's not everything. It doesn't replace the population study, but at least there's some language that would give us some hope.
Mm-hmm. But I think it goes back to the point of where nursing can have a contribution. This is why it's so important that nursing needs to be proactive and sit at the table and have a dialogue as they're thinking about designing these kinds of things, and to continue to push forward for having input as this begins to conceptualize itself and grow over time.
Terrific. Well, thank you very much, all three of you. Hopefully that gives you a view of the future. Thank you.
And I also want to thank the panel, and Connie Ulrich has been the co-chair, the lead co-chair of our bioethics committee. And Connie, I hear an Academy position paper in here. And I also want to thank Noam. He received one of our media awards last year for an article he published in the New York Times. Thank you so much. Thank you so much.